Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, everyone. Thank you for joining us for today's webinar on creating a quality improvement plan for home health and hospice value-based success. Well, my name is Awoniyi, and I'm the Director of Clinical Education and Patient Engagement here at Axxess. Axxess is a leading healthcare technology company offering a complete suite of easy-to-use software solutions that empower home health, hospice, home care, and palliative care providers to grow their business while making lives better. And I'm truly delighted and honored to be here with an esteemed panel. Joining us for today's webinar will be Charity Farnsworth, Senior Vice President of Consulting Services of Healthcare ConsultLink, Zaundra Ellis, Senior Director of Hospice and Palliative Care Solutions here at Axxess, and Arlene Maxim, Senior Vice President for Clinical Services for Axxess. Obviously, there's always housekeeping to be done, and so before we begin, your phones and your lines have been muted, but you may still submit questions through the chat function. If at any time we're able to answer towards the end, we will take as many questions as possible. But rest assured that any unanswered questions, we will respond to you after the webinar. And slides from today's presentations, along with the recording of the webinar, will be available and will be sent by Aging Media to all who registered via email. They'll also be posted in the Axxess Help Center for those who are familiar with that. In terms of our agenda for today and what we hope to cover, we're looking forward to providing a background and overview of quality improvement programs. A number of you are running very successful programs, but some of you may be looking for some additional assistance there. So we look forward to speaking to the essential elements of an effective QAPI program. We'll review common survey citations and how to essentially use quality assessment, performance improvement, and continuous quality improvement to prevent and to improve those, and then provide approaches and share best practices for how to measure and sustain your QAPI program success, along with recommendations for approaching care quality and the patient experience. Before we dive in with the panelists, part of what we wanted to share with you to provide a framework and to frame the work of doing quality improvement in your organizations is really to take a look at what is CMS's quality strategy, aim, and what are their goals. And a number of you may be familiar with this. To those who may not, we'd love to share this with you, and it's included in the references as well. And you can be assured that if you're trying to understand where CMS is going, taking a look at their quality strategy goals are a great way to understand exactly where they're going and ensure that your programs are aligned with this. So you'll see that there's 6 goals that are listed: making care safer by reducing harm caused by a number of different factors while care is being delivered. There's nothing worse than going in for a so-called minor procedure and leaving with something that's a lot worse. So that's one of CMS's goals: helping patients and their families to become involved in their care as partners of care. And we'll talk about how to engage patients a little bit later. Promoting effective communication and coordination of care. We know that this is that there's quite a bit mentioned around this as well. And then, due to the heavy costs and complexity of chronic disease, promoting effective prevention and treatment, of chronic disease, working with communities to help people live healthy lives, and then ensuring that we do all of this affordably. So these are the six goals that CMS has around the quality strategy. And we can see that within it are three aims, which are ensuring that the care that's provided is better, that we do that affordably, and that we have healthier people and healthier communities. And I'll bring in our panelists at this point to maybe share any thoughts or insights that they have as we think of this as a framework for the rest of our discussion this afternoon.
Well, Dr. Andrew, this is Charity. I'll go ahead and contribute. I do think that, and especially as a clinician myself, we are always about providing the best care to the patients. But I think one thing that we have discovered over the years is that healthcare is a business, and we have to be able to manage our business effectively and do that efficiently from a cost perspective in order to be able to continue providing that care. So, I do think that these are very much in alignment with what we're seeing in the industry and the goals that we have across the boards. So.
Great. Thank you so much, Charity.
And I think too, along with that, Charity, I think that we have to remember that we are going into a value-based purchasing world, and that these goals are going to be the drivers for us as we go into January, and our QAPI programs are going to have to be just very dynamic and an ongoing program. And CMS has given us a gift of time over the past few years to get this together. I think hospice has actually, we discussed this a little bit earlier, I think hospice has done a little better job than we have in getting quality assurance programs together. We've had the requirements since 2018, but this year we really have to get serious about it. And as we go through these slides today, we'll talk a little bit. I think Charity and Zaundra and I can talk a little bit about what we're seeing with surveyors. They're actually looking at as far as quality control standards revolving around this whole intent behind CMS.
Yeah, I think you're right, Arlene, that it's not just about providing the care, it's about doing a good job of providing the care. And that is, of course, what they're trying to measure, and to make the agencies, aware of what they need to do, as well as, the agencies that do better at it will benefit more, and the ones that don't will obviously, see more of a negative impact. So.
Right.
Great.
I just want to hop in here quickly, Dr. Andrew. I think it's important as we go into this that, our audience understands the importance of non-clinical leaders and their relationship with a QAPI program, right? I'm not a nurse. I play one on TV, or maybe I know enough to be dangerous. But when it comes to hospice anyways, I'm good at that. But, that's really kind of, having a strong QAPI program from the beginning as part of my strategy as a leader really helped me understand what was going on and make sure we have the resources and the structures in place to provide compliant care. Right. So if you're not a clinician and you're on this call, it's really super important that you dig in and get a head start on this.
Right.
And I think appreciate those points, because I think we've all heard of the Triple Aim, and just looking at this CMS quality strategy goals, the aims that are on the inside seem to all speak to the Triple Aim. However, a number of us have also heard of the Quadruple Aim, and essentially the Quadruple Aim adds the dimension of increasing provider satisfaction. With I think most of us would agree, COVID clearly helped really show the importance of taking care of our providers as we think of a quality improvement program. You know, we can see here in this diagram with the quadruple aim that increasing provider satisfaction is one of those items there. So as we really think about our topic of having a solid quality improvement program, and we tie that to value-based purchasing or VBID in the case of hospice, how should organizations really think about tying this together? Maybe it's obvious, but if any one of you could speak to that real briefly.
Well, I can tell you that this whole dynamic here is really, really interesting, because what CMS is actually trying to do is to encourage patients and their caregivers to take more responsibility for their health. So this all kind of revolves around that. So the increased provider satisfaction is absolutely clear, not just necessarily a result. I think that they had planned that before, but clearly with COVID, we found that we have to make sure that we take care of our providers, because we are losing providers at a pace that we're not able to keep up. We have to start looking at, I know that Axxess is sponsoring this, and I think it's really important for people to understand how important it is to have a software program and data that you can rely on that show that you are working toward a quality program that allows patients to understand how to take care of themselves, allows caregivers to understand how to take care of their families. Population health issues are also built into that, but how they're going to reducing the cost of care, because Medicare, we've heard for years that Medicare is going to go bankrupt, and it seems to be getting closer and closer every day. And we have so many senior citizens coming. We have not reached the peak of senior tsunami yet. That will be coming in the next 20 years or so. But I just think that everyone really needs to take a really hard look at this quadruple aim to see what a CMS's intent is, and then work toward that within their QAPI program, within their organizations, to reach that goal.
Yeah, and Arlene, I think you hit on a good point there too about incorporating the staff and really looking at the provider satisfaction, because I think we all know that if we only focus on the patients, we're missing that key component. And when you talk about providing care, providers who have a higher level of satisfaction in their roles at their employers, their agencies, they're going to give better care, and they're going to be more compliant with expectations when it comes to documentation and following the processes that we need them to follow in order to meet the expectations for value-based care. In other words, we're going to have certain measures that they're going to be looking at for the purposes of identifying how an agency is performing. And as we all learned in first semester of nursing school, for those of us that are clinicians, if you didn't write it, you didn't do it. And if you have staff who are not engaged and they're not really making that effort to document the way that they need to, whether they're providing great on-site care or not, it's not going to come out in the end the way that the agency needs it to, which then circles back to, if the agency is impacted negatively from a financial standpoint, that's going to potentially impact what they can do for their staff and their providers in the agency. So I think you get that cyclical impact. And so looking at all of these things together really is a requirement, not an option. And the quality program fits into that because it does measure a number of things that hit all of these areas.
Yeah, true.
I appreciate both of those points, because we hear the AAA, we hear and as we find ourselves looking at quality improvement programs, it can be easy to sometimes become fatigued, as it were, but realizing that this is here to stay. This is essentially what CMS has said. These are the areas that we need to ensure that we continue to address to really move our healthcare system in the right direction. And Arlene, you talked about the Medicare trust funds. I think I remember there were some Gen Zers that they pretty much concluded that there will be nothing left by the time they're 65 years and older, and so a number of them are making plans otherwise. But apart from the Medicare Trust Fund, we know that we all want to receive the best care possible, and this framework really serves as something that works nationally or even internationally, and works at the local care organization as well, whether it's home care, hospice, palliative, or home health.
Yeah, and when you talked about, Emily, you talked about the safety issues involved in that, the safest place for people to be is at home. And so I think, that our quality program, it has to be so specific to the home environment, and that we are able to show how we can improve the care at home. That's the safest place for people to be. And the safety issues all are combined with this, and certainly keeping those patients safe reduces the cost of care. You don't have those rehospitalizations and that type of thing. So I think it's really important for people to think about that and how important it is. And I'm sure we'll get into that in some later slides about some of the issues revolving around OASIS and OASIS-E, and things that we need to be looking at, and with hospice, with their evaluation, things that we need to be looking at to keep these people safe, improve population health, and get these people to be more responsible for their own care and their own health.
Thank you. Why don't we move forward? Like you mentioned, Arlene, we know there's still a few more things we want to cover. We'll go ahead and actually hear from our audience and participants in terms of a poll. So on your screen, you should shortly see a poll if you don't already. On a scale of 1 to 5, with 5 being the most prepared, how would you rate your organization's preparation for value-based purchasing or value-based insurance design, in terms of really based on the points shared so far by the panelists? Okay, we'll leave that up for a few more seconds to give everyone a chance to respond to the poll. Okay. And we'll take a look at the poll result so that we can all see the level of preparation. Okay. We can see that the majority have started preparing. If we can keep the poll up just so that we can all see that and just speak to it briefly. Thank you. The majority have started preparing. Neutral, somewhat prepared is next. We appreciate those of you who are brave enough to say that you're not prepared, or your organization is not prepared at all. And the 6% that say they're fully prepared. I'm wondering, Zaundra, did these results surprise you at all from a hospice perspective in terms of preparation?
I'm delighted that to see that we've got people that are on track and somewhat prepared and fully prepared. I think those numbers are very encouraging, along with that we've started, right? The conditions of participation for hospice are usually effective on October 1st, right? So, with home health being January 1st, it's great to see, several months out that everybody's working on it, right? And if you haven't started, it's not too late. I mean, I was thinking back to October 1st of 2010, when hospice had the quality assurance performance improvement condition of participation introduced. And I remember I was thinking about, we really weren't that prepared for it. And I think we grew up with it, or my organizations, we grew up with it. So no matter where you are in the process of preparing, it's a good time to make progress. And if you're fully prepared, you know, I think we make the industry stronger by sharing best practices. So I think that's important as well, Dr. Andrew.
Thank you, Zaundra. And any quick comments from Arlene or Charity regarding the poll results and what it shows, our insights?
Yeah, I guess I agree with Zaundra. I wish there was a higher percent, because the greatest percent are those that are neutral or somewhat prepared. It kind of seems like they're not really sure where they're going with that. So it'd be interesting to find out from folks too what they would need in preparation. We would like, as consultants, we would like to know what folks out there would like to see in getting prepared. Do they need help? Do they not fully understand the whole process? That type of thing. But it is encouraging that 34% have started, 6%. That's 40% of people that seem like they're about ready to go into value-based purchasing. So that is encouraging.
Great, thank you. And we do have a poll that asks about challenges. We'll work our way through and ensure we get there. We can take down the poll now. Thank you. And we appreciate you providing us some insights from that. In this next section, we just wanted to talk a little bit about some of the definitions. We know that Zaundra had alluded to the fact that back in 2010, 2011, Hospice had received in their COPs the requirement for QAPI. And in the case of home health, it's a little bit more recent. And just asking Arlene and Charity, in terms of some of the major home health survey citations you've seen around quality improvement, what are some of those citations? And maybe you can also share a little bit on what your thoughts are on how they can be prevented, or how organizations can.
Charity, you want to start?
Sure. Well, I think one of the ones that we see on a regular basis has to do with the plan of care. You know, we've talked about the patients being more engaged in their care and their caregivers being more engaged. You know, not individualizing the plan of care is a pretty consistent one that we see when we talk with our clients and when we get requests for plans of correction, you know, for both accredited and non-accredited agencies. I think that one is one that's really coming out, because we're past the days where it might be that if you had two patients with the same primary diagnosis, that their care plans were effectively the same as far as interventions. It really does need to be more patient specific. It needs to be more identified with the goals that the patient themselves has, because we know that in 2018, when the COPs changed, you know, the patient language, you know, became a very important part of making sure that we stated things, not only how we see them as clinicians, but how they actually need to be stated from the patient perspective also. Not following the plan of care is another one that's related to that, whether it's wound care or other interventions that, you know, the agencies may not be following the plan of care the way that it's actually outlined, and even frequencies. Those are, I guess you could call them low-hanging fruit, you know, for a surveyor, because they're very easy for a clinician to get in a hurry and just give the standard answer and move on and push it through like that without really customizing. So I think that one is a really big one. And there are even, alongside that, some regular deficiencies that we see related to just basic paperwork, you know, consents, other documents that they sound like they're not, quote, that big of a deal from a paperwork perspective, although we know the reason they're there is a very important one. But I think they're often taken for granted that they're being done the way that they should. And if the QAPI program is not structured in order to look for those, as well as the clinical aspects, I think there are gaps in that case. So I would say, you know, initially right off the bat, those are some that we see on a regular basis. But Arlene, you may have some additional ones.
Well, I've had the opportunity, I guess, to help write some plans of corrections recently, and they involve the entire condition. And so all of the components, the G tags underneath the condition were all cited. The agency did not have a quality assessment tool that they were using. They had not completed the documentation that was necessary for the survey to determine whether or not they had a quality improvement program together. I've had a couple of those. They're really looking, that seems to be one of the #1 citations that are being looked at as they go through the survey process. And I guess it depends on the accreditation body too. If it's a state organization, the state certainly is looking at QAPI and then the emergency plan. The one thing about the QAPI requirement, and it's not on this particular piece, but it's on another piece that talks about the board of directors being so involved. And oftentimes we don't have those minutes that address the board of directors taking part in the implementation and getting the program put together and determining what the PIs are going to be and that type of thing. So my one piece of advice to everyone is to really look at this very carefully and make sure that you're following all the components that are necessary in designing your QAPI program, and that the board is taking an active part in it. We've had, I think, for many, many years, well, from the time I think I've gotten into this business, the board of directors oftentimes are people that come into the office a couple times a year and sign notes to say we had a board meeting and weren't really involved. Now, QAPI actually has forced the board to take more of an interactive response with the home care agency.
Yeah, and Arlene, in addition to the board of directors, I think it involving more of a team approach to the QAPI. We have seen, and unfortunately, especially during COVID, when staffing became an issue and administrators had to go into the field, we've seen a number of agencies get pretty far behind on their QAPI. Yes. So they are getting more deficiencies, like you said, for not having their QAPI completed, but also not having their staff engaged so that it is a more comprehensive QAPI. Did you have the different disciplines represented, and were they involved in, patient record reviews and other aspects of QAPI? I think those are all things that they come from some of the challenges that we're seeing as an industry, but there are also deficiencies, that agencies are seeing when they realize that they're either behind and they haven't done it, or they've done a poor job of it, or, they have people who effectively just came in and signed a piece of paper, whether they were on the board or maybe they were even just on the QAPI committee from other disciplines, and one person did everything and they came in and signed off and don't even know what's in the QAPI. So
yeah, I agree.
So it sounds, and thank you for sharing those perspectives, and I suspect that there are probably some other areas that some other organizations may face, but at least you've given us what some of the most common ones are. And so for organizations that may still be struggling in those areas, I think you've also provided some insights on how they can ensure that they address the documentation piece around the plan of care. And that's really where software can be extremely helpful, and that's putting in processes in place really around, even if it's doing a random sample, a sample review, just to ensure that plans of care are really being followed. And if there's any sort of reporting that's easy to pull out from a system, it sounds like would be helpful. And then with those, when you talked about the executive responsibility and the need to ensure that the board is informed and isn't simply signing off, and those people who may be on a board in our audience, asking at least a few questions around how the organization continues to carry out their QAPI program. I know that we also, from a hospice perspective, there's also the requirement there for QAPI. Wondering, Arlene, I'm sorry, Zaundra, whether you had any perspective in terms of what most hospice organizations may be struggling with.
I do. I think, and I'm grateful for the opportunity to talk to many different hospice providers routinely, right? And to understand their struggles, and sometimes I think QAPI seems like it's so big, right? it's so big that, you know, we're kind of destined to fail. So we're just going to do the bare minimum and see if we get by, right? And they really struggle with that. When in reality, quality should be part of the culture of your organization. You should have systems in place, time frames in place where you measure certain things, daily, weekly, monthly, quarterly, annually. And I think people really get tripped up with, how do I get all of this done? But when we take it apart and kind of put it back together in smaller pieces, it makes it more manageable, and it also makes it more effective, right? And I was thinking about Charity when she was talking about, you know, the staffing issues, right? Hospice has had staffing issues as well. So, you know, if I was consulting a client and they were having issues getting QAPI done because of staffing, I would write a performance improvement plan for that. And I would put that in my QAPI program. I'm addressing it because one of the things that, you know, CMS is looking for is the organization's ability to demonstrate the QAPI operations, right? So there's no better example of, we have a problem, we don't have enough people. Every organization that's short-staffed should have a QA. It should be the QAPI program, and they should have a performance improvement plan and take credit for the work that they're doing to retain and recruit their staff.
And
Zaundra.
go ahead.
Oh, I'm sorry, Dr. Andrew.
No, go for it, Charity.
Well, I was just going to say, you know, one of the deficiencies we are seeing is not having PIPs when it's indicated that a PIP is needed, at least on the home health side, and you may be seeing that for hospice as well. And I think that ties into what you're saying is, you need to have it, but you also need to treat QAPI and the PIPs like a living, breathing document. It's not you write it, you fill it out, you sit it on a shelf, and then you go about your business for 3 more months until you do it again. You know, it's meant to be a living, breathing document that is worked on a regular basis so that you can see that progress to goal and hopefully discover that when you get to your next QAPI, that you don't have that issue and you've made progress on your PIP, whether it's home health or hospice.
And thank you for mentioning the dynamic nature of it, Charity. You know, and Zaundra for pointing out the fact that, you know, the reality is, we're not penalized for finding a problem. We're penalized for not fixing the problem. And so most of the time we understand what the problems are in our organizations. And so it really is about what are we doing to fix it, and understanding how to write those pieces and continuing to tell the story, as it were, in terms of, we identified a problem and here's what we've done to fix it. And most of the time we're not penalized for continuing to work on the problem and addressing the most egregious parts of whatever the issue is. So really appreciate that point. And why don't we go ahead and hear from our audience again, and put up the second poll, since we've been talking about a QAPI, and really begin to get a sense for what our organizations may have in terms of their awareness and communication of their organization's current written QAPI plan. And I'm sure our panelists will have a few things to say after we see what the results are on this. So just asking our audience again, in terms of whether you are aware of what the performance measures are in your organization's your current written QAPI plan. Okay, and we'll give it about 5 more seconds. Well, if you don't mind showing the results.
Oh, good.
Okay. We love results like this. Don't worry, there's not a follow-up question asking you to list them. but it looks like the majority of participants say yes. Just real quick, wondering what your thoughts are from our panelists.
Well, I think that's excellent. 86% of the people know what their PIs are. That's pretty impressive. I can tell you that some of the QAPI programs that I've looked at that people have tried to put into place, and I know that surveyors have also comment, they put way too many PIs in there, and it's very difficult when you find 26 things you want to correct and you list them all as PIs. It's very difficult to actually be able to act on that. So it's better to have fewer. Most surveyors, and Zaundra and Charity, correct me if you see something different, most surveyors only looking for 2 to 3 PIs when they're in the organizations and looking at their programs. So it's better to have a few and do a really, really good job than to have a whole list of them. Now, I know that this doesn't tell us how many PIs, that we don't talk about numbers here, but it's very impressive that 86% of these people are aware of what their plan is.
You know, I would agree, Arlene, and I think part of that comes with prioritization. You know, every agency is going to have a group of things that they want to work on, but I think by narrowing it down and looking at what are the key priorities right now and the things that are most important or the most critical to get resolved sooner versus later enables the agency to put their efforts and to really focus their team on those few things. Then they would move to the next set of priorities after they see how those outcomes turned out, and then do they need to continue focus on them, or can they move to the next ones in the list, or even reorganize the priority? So
yeah.
So I think here is you know, I kind of, Arlene, that made me laugh. We got 20 things, we have 20 pips going on. You have a whole group there. So I think what's important because we're people dealing with people, right? Things are going to happen every day. So, you know, not everything requires a PIP. But if you have 20 things that you think need a PIP, I would really challenge you to do a root cause analysis for those, because more than likely, most of those are tied together somewhere. And by doing that work and identifying the root cause of it, you can address 15 things at one time in one PIP, right? And just taking that few minutes to document that root cause analysis and explain, you know, we have these problems and they're all related to this, so this is our PIP. You know, that takes care of it. I think, again, don't be overwhelmed, right? Be smart about it.
One thing. Oh, I'm sorry, Doctor.
Oh no, that's okay. I was going to say, you know, that is an excellent point. You know, can we work smarter with you know, putting together some of those PIPs? I'm sorry, go ahead, Arlene.
I think this gives us an opportunity here to, on a couple slides ago, we talked about the safety of the patient again, and immediate jeopardy is real. And I know that surveyors are looking more closely at immediate jeopardy situations now. And QAPI gives us the opportunity to find those, like Zaundra was saying, find the problem before they ongoing process. You're going to be able to address find the problem, address it, and show them what you're doing. You're likely not going to be cited, and probably not going to be cited with immediate jeopardy if you have addressed it and you're doing something about it. The problem I see in agencies is oftentimes they just kind of gloss over things and they don't necessarily want to write them down. They don't have a plan for how they're going to correct something, and that's when you run into particularly safety with patients. That's why it's so that you do such a quality safety assessment to begin with, because that's the one thing that the surveyors will be looking at is, have you kept your patient safe? And is there anything that they're seeing that could jeopardize the safety of the patient? And that's when you get the immediate jeopardy issue. And it doesn't have to happen. It's just the potential for the safety issue to occur.
Well, and just because the problem isn't documented doesn't mean it does not exist.
That's
And
right.
I think that's an important part of it, is glossing over it, like you referenced, Arlene. That may be a temporary solution, but it's not a long-term solution. And ultimately, if they don't get back to the root cause, then they're not really going to fix the problem. They're basically putting a temporary solution in place, or trying to ignore it long enough to hope it will go away, and that doesn't typically happen. So
Immediate jeopardy is painful in many ways. It's painful because of the scrutiny you come under, but it's very painful financially. And so we have huge hits with immediate jeopardy. I've had agencies actually go out of business because they've had immediate jeopardy findings, and it took them so long to get them corrected that money just kept adding up every single day, and they just couldn't sustain business with it. So it's very important that that agencies consider that when they're developing their PI plan.
right.
And appreciate all those contributions and the thoughts shared there in terms of really weighing for, is it worth the effort up front to invest the time up front, as busy as we are, to prevent the costs, like you mentioned, with immediate jeopardy with the patient, and continuing to evaluate that on an ongoing basis. And we know organizations are dealing with a lot, but the last thing we need is to have less care providers out there caring for all the needs that continue to be out there. I think part of what we had wanted to do is just talking a little bit, and we've touched on this in some ways in terms of clinical documentation integrity, and just wanted to share, what our thoughts are around the clinical documentation improvement initiatives that most organizations will also engage in, and just wanted to check in real briefly with our panelists around, and you've alluded to it in terms of, just because it's not, I think it was Charity that made the point, just because it's not documented doesn't mean it doesn't exist, and if it wasn't documented, doesn't mean it was done. So, and any thoughts around the role of technology with really being able to, as an organization, for those participating today, to really leverage technology to help them with their quality improvement programs, and obviously preparing for value-based purchasing and value-based insurance design.
Sure.
Thoughts around that?
Well, and as a consulting firm, I know at HCL we see quite a few different technology platforms in use in home health and hospice, and it's not difficult to see at times that the ones that are built more to have certain workflow built in, or certain components that are helping to get the documentation done properly, or pointing people in the right direction, are often the ones where we see the documentation being done more as we would expect it to be, which of course means the outcomes of the QAPI are better. I do think it plays a key part, because one of the things that we see with the more more basic programs is that they don't include as much, I guess you could say, coaching type build in order to help the agencies know what they need to be putting in or what's important. And they're not going to know everything they need to know. And so this is a way to kind of point them in that direction and help them to get that documentation done, even if the system is forcing them to do it, and that's why they're doing it.
I think it's interesting because, we had a lot of talk at Axxess about palliative care and hospice and hospice and home care. And it's CDI is kind of that same thing with palliative care. Everybody has their own definition of what palliative care is. CDI is the same thing. Everybody has their own definition of what CDI is. And I think that in our industry, it doesn't seem, and I may just not know where it is, I have not seen anyone as an industry leader take on that CDI role for home health care. Zaundra, I don't know, maybe they have something for hospice, but for home care, they have formal CDI programs for hospitals, for physicians' offices, for nursing homes. I have not seen one. And a CDI program, to me, is something very structured. And if you see this in the documentation, then this is your next step that you have to take. So it should be a formal process to go through a CDI program, so you can measure it to see if it's working. That you can measure it, you can see the quality of care of the patient as part of your quality program. So like I said, the same issue we have with the definition of palliative care, you have the same thing with CDI. Everybody has their own definition of it, and I could ask a number of 10 agencies, do you have a CDI program? They're all going to say yes. I look at the documentation, and the documentation is not good. And there's not follow through. And so I think that people really need to, I think we as an industry need to get a hold of this and take the lead in creating a CDI program for ourselves that's formal, that universally it's done pretty much the same way. I don't know, Charity or Zaundra, maybe you have some other thoughts on that. That's how I see it.
No, I would agree. And I think that would improve the consistency, which would then also enable the companies that are developing the technology to build those things in so that there is a more consistent entry of the information, which then, of course, facilitates the CDI program components being met the way that you would want them to be met. Because I do agree, if you ask, multiple people about it, for starters, some of them are going to say, what's a CDI? And then the ones who do know what a CDI is will give you that different definition, and it is hard to get consistency. And even when clinicians may move from organization to organization, what they did at one organization may not be the same at the next.
Right.
And I think the training is an important aspect of that, whether they're new to the industry or they're just coming over from somewhere else. Just because one agency's definition of what that program is does not mean that that's the same definition that another organization would have.
Yeah. I know AHIMA has some very specific guidelines for like physicians' offices and hospitals, and it's consistent all the way across the board for all the physicians and everybody in the hospital. And so that's what I see. And I do think Axxess does a really good job of getting the data collected. We just have to know how to move it through and recognize what we need to, how we need to respond to the information we have. And so I don't know, Zaundra, if you have any other ideas on that?
Well, I think fundamentally, back when hospice had the QAPI requirement, and Jerry, you may remember this, back in the day, clinical leaders at hospice organizations, large and small, spent hours and hours every day reading through every note and signing off on it before it went into the chart. That is a basic CDI program. Has that come along? Yes, it has. It's grown up some, but there's always room for improvement, right? And it gives a good opportunity. CDI programs are an excellent opportunity just to make sure. Charity talked earlier about hey, plans of care are not followed. They're not consistent. Those things. In my mind, as a non-clinician, those notes, that plan of care, the orders, they're in a line, right? And they should be in alignment, right? And so the challenge of CDI for hospice is, how do we do that? And dealing with dying patients where they have different needs than home care patients who we expect to have these points of recovery. If they've fractured their hip and they're doing rehab at home, hospice patients, it's like a baby being born. Every birth is different and every death is different. So, it's a little challenging to capture all of that in the CDI program on the hospice side. I don't know what you think, Charity, but.
No, I would agree completely.
Yeah, and the reality is, documentation is as unique as each clinician, and I think what I've heard you say consistently throughout this piece is, documentation, a clinical documentation improvement project will always be something that will be ongoing. you have new providers that join or new clinicians that join, old ones that leave. And so there's a certain cadence. But at the end of the day, the goal is really, how do we tell the story, not too succinctly, but at the same time, not too verbose where you're just trying to understand exactly what the patient's problem was, therefore what the intervention is, what the outcomes are, so that the next provider can understand what they need to do in order to move that patient closer to the desired outcomes. And obviously technology should not get in the way. It really should enable that process. And there isn't a perfect solution out there, but I think it's something that we continue to strive for clearly. And I know we had also included sort of the continuous quality improvement, just included the definition, and we've been speaking to that, especially whether it's the documentation piece or as part of a QAPI program. And we'd also, at least on the home health side, had just included an illustration of if an organization is working on you know, improving their measures for, let's say, OASIS in the case of home health, how that translates into quality measures, both for care compare, when that reporting is done, the star ratings, and as we can see, even from a PDGM and ultimately VBP perspective. And we don't have this fully yet for hospice, but I'm sure this serves as insights into how an organization can build on what they're doing and using that to check off a number of different boxes. Just looking at really getting some more into the standards of QAPI, and I believe we've touched on this in a number of different ways. Did want to bring in, as we think about QAPI and the standards of QAPI and the incredible job that was done by the home health quality improvement initiatives, that I think that was a 5-year grant that finally ran out, but they did a great job in pulling it together a number of resources. We've touched briefly on patient engagement and some specific areas in which CAP surveys can be used by organizations in their QAPI program, and just wanted to see if there were any quick thoughts around that before we move to IDG.
Well, I think that, like, just briefly, I think that folks really need to pay attention to their CAPS program that they have, where they're getting their information from, how they're doing it, because CAPS results is going to have a huge impact on value-based purchasing. There's like 30% of the money, the points that are allocated for value-based purchasing has to do with patient satisfaction. And right now, I mean, if you look at some of the CAP scores, that's one of the places that are scored the lowest. Patients either forget that you were ever there, or they haven't had a good experience, but rarely are they saying that they're going to recommend a particular agency to a friend or relative or anything. All of that has to change. We need to really start focusing on those CAPS questions. I mean, these are the things, what you have on the screen right now, Dr. Andrew, are the things that I was mentioning earlier that the surveyors are hitting. They're looking at program scope, they're looking at program data, they're hitting each one of these, and agencies are being cited on them if they don't address them. But certainly the CAPS program, patient satisfaction, people really need to take a really hard look at that and realize it's going to impact their payment in the future with value-based purchasing.
And I think part of that, Arlene, is making sure that the staff understand that, you know, training the staff on CAPS and the impact that it will have and their part in that. Because when you think about who the patients are seeing and who the family members are seeing, it's not the people sitting in the back office. They may speak to them on the phone, but ultimately the face of the organization is the clinician who's going out to see the patient, who's providing that care, who's also the person who can be trained to go out and talk to the patient using some of the terminology that they may have presented in the survey. You know, if they're using the same type of verbiage that the patient will see whenever they are completing that survey, and being encouraged that they may get a survey and to return it, you know, I think those are the types of things that agencies can do to impact their CAPS, and also understand if there are patient dissatisfaction points along the way, what can they do to address them before they get to the point where you can't change it. Maybe you've gotten fired as an agency, the patient's not on service, and you're definitely not going to get a recommendation from them in that case. So I think it's engaging the staff and doing it as a process, and realizing that you can't just wait and see what the patient sends in, because by then it's too late.
Yeah, thank you so much. But yeah, I think we're under the 5-minute mark, and just so much good stuff. I guess the audience is going to have to invite us back in order to bottle all the great knowledge that's being shared here. I know we had included in our handouts just the, you know, Institute for Healthcare Improvement model for improvement, and I think a lot of people are familiar with the Plan, Do, Study, Act, and wanted to get to. I know we had one more poll, and if we can just quickly do the poll in terms of some of the key challenges, only because this was brought up, and then we'll wrap up with some final thoughts after we share an outline for a QAPI program and areas to focus on for improvement. So what are the key challenges your organization's facing in implementing and maintaining a successful QAPI program? And this is multi-select, so please feel free to select the key challenges your organization's facing in implementing and maintaining a successful QAPI program. And let's go ahead and close that poll and just take a quick look at the results of that. And I know Arlene had asked if we can find out what the key areas or the key challenges are. Well, it looks like staffing and then motivating staff, which were areas that you had touched on, followed by tracking and analyzing QAPI performance measure data. So it sounds like maybe that if when we come back again, that will be an area of focus. If we can take down the poll, and we'll just share our one of our final slides. And if we can just, if each of the panelists can go around in, should we say, in 20 seconds or less, and thinking about what we've talked about, what you want take-home points to be around areas that organizations can work to really develop a QAPI plan program for measuring success.
Well, I don't mind starting.
Okay.
I think for starters, the agency needs to look at what they're doing well and what they aren't doing as well, and really be honest with themselves about it. I think the leadership of the agency needs to do that, and then identify how to incorporate all of the staff to do that, to address the issue.
Thank you.
So I'll hop in real quick. I think it's, sorry, Arlene, I'm sorry. I think it's important for providers to see this as an opportunity and a path to compliance. so that you're on the same page with your site visitors or your surveyors, and that you're all working in the same direction, that you have clear direction. You know, it's all in the execution. So I think it's a great opportunity. I'm excited to see how this grows for home health.
Great.
You know, years ago, we used to have to do something called an annual program evaluation. And in that annual program evaluation, we assessed how we were doing, if we were still working on a project, and what our plan, what our goal was for that. And I think that we all need to do something like that in evaluating our QAPI program on an ongoing basis. I don't think it's a one and done type of thing. I think that agencies need to take a look at their QAPI program, look at what they feel like they need to have included in it, whether they're working on it, what they're doing about it, and then when they've actually reached their goal, and then reassess it. So it's almost like doing a patient assessment. You have to do your evaluation, determine what your plan is, and then complete your goals. So, you know, if you keep that in mind and look at all those G tags underneath that condition, and make sure that you've got all of those covered before you have your next survey. That's one of the keys to success with QAPI.
Yeah, and Dr. Andrew, if I could just add one quick thing along with what I said earlier, I think in preparation for value-based care, I think it's important for the agencies to really look at what are those elements that are going to impact them and their scoring from a value-based purchasing or VBID perspective, you know, to look at those specific measures. How are they doing on them right now? And what do they need to do to improve on them in 2022 before we get to 2023, when the measurement that starts will actually impact their financials. So,
you know, thank you so much. Appreciate that last thought, Charity, Zaundra and Arlene, you know, for sharing your expertise and wisdom with us all today. Unfortunately, we've run out of time, but as a reminder, everyone will receive a link to the slides if you weren't able to download it, and a recording of the webinar. And we just want to thank you all for your time today, and want to also appreciate Home Healthcare News and their partnership in being able to deliver this. And we look forward to seeing you all at our next webinar. Everyone have a wonderful day. Thank you. Bye.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.